This is a 22-year-old male. He's seen in the emergency department for severe fatigue over the past month. He's actually requiring a wheelchair to mobilize any distances. This is to the point that he had to move back in with his parents and actually had to stop his university studies. On review of systems, he has intermittent abdominal discomfort, constipation, dyspnea on exertion, and 27 kilograms of weight gain over the past 2 months.
That's Dr. Stephen Rowe. He's an internal medicine resident at Memorial University of Newfoundland and our guest on this special Medical Mysteries episode of Around the Room. Welcome, everyone. I'm Daniel Ennis, and I am, as always, Watson to my co-hosts, Sherlock Holmes, Dr. Janet Pope. How are you, Janet?
Great. And hi, Daniel. How are you doing? I hear you just moved.
I did, yeah. So to listeners, it's a kind of evening here, late evening in Ontario, and our guest today is presenting from all the way on the East Coast there. And I delayed things because I was just in the process of moving, but thanks to everyone for being patient. And I'm really, Janet, you and I really love doing these episodes, not just because it's no preparation on our behalf, but because
we
there are
like
a lot
that
of
part.
Yeah, sure, we like that part. But also just because it's a lot of fun, and you and I don't think put a ton of pressure on ourselves to get it right every time, and that's not really the point, right? We're just trying to model some clinical reasoning. Maybe I'm modeling like very early practice sort of brain, and you're modeling later practice sort of brain, and so that's why these cases are fun. So maybe with that, we'll hand it over to Stephen. Can you just introduce yourself? It's really lovely to meet you, and we really appreciate you bringing the case.
Yeah, awesome. Likewise. Like you said, I'm Stephen Rowe. I'm an internal medicine resident at MUN in Newfoundland. Very interested in rheumatology, so really excited to be here, guys.
Nice. Me too. I also like rheumatology.
Well, wonderful to have a room keener, and he'll be applying for rheumatology and has done lots of electives. So there you go.
All right. Awesome. Well, Stephen, maybe we'll hand it over to you to give us the story here. I'm going to be scribbling some notes, and then maybe we'll pause you periodically to ask you a bunch of questions, and we'll hand it over to you now. Go for it.
So this is a 22-year-old male. He's seen in the emergency department for severe fatigue over the past month. He's actually requiring a wheelchair to mobilize any distances. This is to the point that he had to move back in with his parents and actually had to stop his university studies. On review of systems, he has intermittent abdominal discomfort, constipation, dyspnea on exertion, and 27 kilograms of weight gain over the past 2 months. He has no joint symptoms and has not noticed any rash. His past medical history is only GERD, for which he takes pantoprazole as needed, and he has no allergies. He does not smoke or use alcohol, and no significant family history. On exam, his vitals are blood pressure 150/90, heart rate 140, resp rate 24, and he's satting 98% on room air. His temp is 37.0 degrees Celsius. He's alert and oriented with mild work of breathing. There's no palpable lymphadenopathy. Oral mucosa is normal, no rashes. The hair and nails look normal. Lungs are clear. His MSK exam is unremarkable with no synovitis. Power is full. His cardiovascular exam, though, is notable for 3+ edema of the lower limbs up to the abdominal wall. The abdomen is distended, but soft and non-tender. And lastly, he does have a positive Castell sign, indicating mild splenomegaly. So guys, any initial thoughts at this point? And any spidey senses tingling for something rheumatological from this initial little bit?
I have a non-medical thought. I love that accent. I think it's super great. And in terms of medical thoughts, just like as you were going through it, I was thinking like, wow, that amount of weight gain. Like I watched Super Size Me, where he was like eating McDonald's every day. I don't think he gained that much weight in a month. I don't remember it that well, but I think like the point being like, if you're gaining that much weight, there's a very good chance that it's water weight, as opposed to like, oh, he's gaining fat or gaining muscle, right? Gaining muscle is usually not a medical concern. So that's rarely a problem that we see, but that definitely sounds like water. So then when you tell us that he has a ton of edema, that's actually that's actually kind of fitting with, trying to connect the dots between like history and physical exam. That's starting to fit. I think it's interesting that he's edematous, and for a 22-year-old, seems like he's hypertensive. If that's actually the blood pressure he's walking around with, it's totally not normal. That he's tachycardic. So this, maybe as an internal medicine resident, Stephen, I expect kind of your first decision tree is like, is this person sick or not sick? Like, do they need an admission? Is this an emergency, or is this, Emerge asked us to see it, but like this is outpatient stuff? I would say like these vitals in that story means this person's sick. So, an important person to kind of work up quickly. Janet, what was on your mind up front?
All those things for sure. Obviously, it's acute on subacute. I won't call it chronic yet, but it was enough for the kid to unfortunately have to stop uni and move back with his parents. And 27 kilos doesn't happen overnight. So the kinds of things we're thinking, because this is a room mystery, is it rheumatologic or not? Has this kid got like a myocarditis or pericarditis? We haven't heard what his JVP is yet, and I'm sure we're going to hear more. He's got presumably some splenomegaly, which is probably hard to tell because he probably, with his anasarca, he might also have some edema in his belly that's not related to liver things. We're not told he's yellow or anything like that, so we don't think he's in any hepatic failure. So I think cardiac is what I'm thinking, and is this really a heart pump issue that could be something related to one of our diseases or not, a post-viral, a post-infectious, a weird cardiomyopathy, but also some of our connective tissue diseases, rarer in a man than a woman, but could be potentially on the list. Even RA can have a cardiomyopathy or pericardial effusion. But I think what we need probably now is a few more tests to hear some things about his JVP, his CK, his tropes, chest x-ray. I think all those things would be helpful. And then our usual routine biochem is CBC, diff, creatinine, some liver enzymes, urinalysis, because I don't think he's anasarca and so tachycardic alone from something like nephrotic, nephritic, or membranous GN. I think the money might be where the heart is, but I'm just hazarding a guess.
Okay, so those are some opening thoughts. So, Stephen, maybe we'll hand it back to you. What were you folks thinking when you first saw him?
After we just took the quick history and physical, we did a quick chat review. And there was something actually pretty interesting when we looked back on the EMR. About a month prior to this, he had blood work with his family doctor that showed a CRP of 100. And then they repeated it a week later, and it was 197.9. His family doctor then arranged a CT abdo-pelvis that did show poorly defined heterogeneous bilateral adrenal lesions surrounded by diffuse fat stranding. And the differential on the scan report was adrenal masses versus adrenal hemorrhage. There was also splenomegaly at 15 centimeters and lymphadenopathy with mildly enlarged porticable, periaortic, and mesenteric lymph nodes, but just up to 1.2 centimeters. It's pretty small and favored reactive on the scan report. Interestingly, he also went to the ED 1 week ago, and they found that his hemoglobin had dropped 59 points. So his hemoglobin was 118 last week from 177 just a month prior. At that point in Emerge, they booked him for an urgent outpatient scope to investigate the anemia, but it hasn't happened yet. So before I get to today's investigations and so on, does that change any of the calculus here, guys?
So sorry, his platelets and other blood counts were stable?
On the previous blood work, yes.
Okay, and his renal function was okay on the previous blood work?
Yes.
Okay.
And presumably the initial labs from the family physician with the CRP of 100 was because this was already going on a few weeks before or a month before, whatever it was. And the poor guy has come to emergency room at least one other time. So adrenal lesions, that could have been a bleed versus fat stranding. That's really unusual, and just as something that I'm not thinking high right now. APS can certainly give adrenal hemorrhages, but bilateral at the same time would be weird. And if he's APS, we really have no explanation for his anasarca. It's not like this guy came in with an acute PE or saddle thrombi to cause a majority that would have to be like the whomping right heart failure. So I'm not sure what to make of the adrenal lesions right now. We certainly know he's tachycardic and hypertensive. Well, in Emerge, he's not hypotensive, and we don't know about his lights, but I'll just assume he's not Addisonian from this. The shoddy lymphadenopathy, that's in the abdominal, I guess. It's pretty non-specific. Could be post-viral. Everything could always be sarcoidosis, but I'm really not sure what's going on. And he might have been hemo concentrated with a hemoglobin of 177, but now at 118, with lots of water on board, so to speak, he could be hemodiluted. But either way, we can't explain that big drop yet. So either he has anemia of chronic disease, his bone marrow's done, something we think might be going on with the spleen, because there's no mention on CT of portal hypertension that we could see, and no mention of liver disease that would be more chronic. Well, usually more chronic, like cirrhosis is not going to be acute, or other fatty liver kinds of pictures. So I'm still fairly stumped, and I'm going to want more data. Daniel, do you have something to add to that?
I suppose when we have these like very strange cases, there's some good internists out here who like to kind of characterize like what's like the window into the case. It just as an example, like working up fever is hard. Working up something really specific is sometimes easier in a sense. And Jenna already outlined some of like the causes of adrenal hemorrhage or adrenal apoplexy, but I think like I don't have off the top of my head a differential that's much larger than that. Like certain infections can cause it and sepsis can cause it, but how about our diseases like outside of lupus and antiphospholipid? I'm not sure. And so I would have to kind of think about that. And maybe that is the narrowest window into the story. Because if you find like, oh, well, that's a not uncommon feature of Castleman's or something, then you go, oh, okay. Well, I've never seen that with my other rheumatoid arthritis patients or Stills, right? Like you start cutting stuff off the list. And so that can kind of make it easier. I think the degree of edema, the very high CRP, lymphadenopathy, organomegaly, that did at least put into my head some of the, Castleman's sort of spectrum diseases, just because, we've interviewed David Fagenbaum on this podcast. And one of the big components of his presentation was how edematous he was. He was so edematous and so inflamed. And so there's a little flavor of that in here. It's a young guy. So I'll keep those on the list, but like surely we should work through things a little bit,
Right.
Common things being
Right.
common, young guy, tachycardic, blah, blah, blah. It's probably more normal stuff.
The money is either going to be in the heart, like the echo,
Yeah.
or in the low albumin.
Totally.
And I mean, you could do a ferritin, it would humor us a little bit.
That's right. So that was just that was the only thing in addition to all
Right.
of Janet's
Right, because
thoughts.
I mean, thinking Still's disease, I mean, we haven't heard anything about a fever.
Right.
It doesn't sound like he has inflammatory arthritis. I think he's in a wheelchair because he has elephant legs.
Yeah,
Right. All that fluid on board so quickly, right? And he's at risk for ulcers, and he needs to be diuresed, just as an aside. Of course he does. But so I would still wonder about systemic onset JIA, or adult onset stills, really is what I should be saying, adult onset stills. But you're not giving us any kind of stills flavor yet, because we haven't heard about any regular occurring circadian rashes that are, usually daily only. We have rashes or fever.
Mm-hmm.
And we have a sense of foreshadowing that you kind of said his platelets were normal at the last one. Well, we were wondering if they're either way high now or way low.
Totally.
So with that in mind, I think you have to humor us a little bit with some more tests of what we did and what you found. And that way we can sound even smarter.
Yeah, that's right. Quit holding out on us, Stephen.
Yeah.
More data.
I'll cut to the chase. So we've got a whole whack of investigations that were done in Emerge. So his hemoglobin to start is now 103. So it's down another 15 points from just a week prior. And his MCV is 77, so he's slightly microcytic. Platelets are low at 75, and his white count is 10.2. His coags are abnormal too, actually. His INR is 1.78, and his fibrinogen is slightly low, 2.23. D-dimer is 2391, so that's elevated as well. And his APTT is up at 42.7. In terms of his kidney functions, that's also abnormal now. Creatinine is 167. And on the urinalysis, just to cross-reference it, he does have 4+ protein, but no red cells or white cells on the microscopy. And they did do a urine ACR that was slightly elevated, 7.9 milligrams per millimole. In terms of some possible inflammatory markers here, the CRP is 173.8. His albumin is quite low, 18. His ferritin, you had mentioned, Dr. Pope, we did do it. It was elevated, 702, although his iron saturation was actually low at 17%. His LDH, interestingly, was a little bit high, 249, and the urate was up as well at 686. In terms of his sort of liver panel, his ALP was slightly up, 287, although the other stuff was normal. So he had a normal ALT, AST, amylase, lipase, bilirubin. They did do some other labs in terms of anemia in the ED too. I think this was recommended by internal in consult at TSH, B12, CK, SPEP, serum free light chains, all normal. And then ECG, for the record, just confirmed that it was sinus tach. He didn't have AFib or something. They did do some imaging. So because of the high D-dimer, they did a CTPA that ruled out PE, but it did show moderate bilateral pleural effusions. As well in the thorax now, he's got multiple pathologically enlarged mediastinal lymph nodes, just up to 1.4 centimeters, and also numerous paratracheal, subcarinal, bilateral hilar, and bilateral axillary lymph nodes. Because of the adrenal findings, they did do a CT abdo-pelvis with adrenal washout study as recommended by RADS, and they found that he's got enhancing lesions within the adrenal glands, but smaller than before, and they seen a tortuous vessel that tracked to some blood pooling. So basically that, from their report, confirmed resolving adrenal hemorrhages. New findings on the CT abdo-pelvis actually showed subcutaneous anasarca and significant ascites now. And again, just redemonstrated the abdominal lymphadenopathy that the prior scan showed. So that's a whole lot of info that I've given you guys. Does this change anything?
What do you think, Janet? What drew your attention the most here?
What is really weird, by the way, just as an aside, because I'll tell you what's weird in a sec, but doing the urine ACR with 4+ protein doesn't make any sense to me. And it was only slightly up, whatever. But they didn't know when they ordered it, maybe. I mean, fair enough, but just kind of interesting. But the thing that's very unusual is this kid has no cells in this extreme proteinuria. So he's got some protein losing, for lack of a better word, nephropathy problem that isn't like even minimal change. He's a bit old for that, but because that's more in the kids. But even these minimal lesion, big proteinuria things usually are GN. So they'd have red cells, and this kid doesn't have any. obviously he's really sick and I still don't know what's going on. While he's being treated with diuresing and possibly working him up in case if he's going to need blood if the hemoglobin keeps going down. I think, the money might really be in the lymphadenopathy. It could be all reactive, but if there was a lymph node that they could kind of slightly easily get at with a fine needle or a bigger needle, but with something not like obviously not an open area thing, that might be something to do to kind of give us an answer. It sounds like, an echo might get done. The pleural effusions are probably transidative and not exudative, I would certainly guess, just because his albumin's in his boots. No surprise. That's kind of what we thought. But low albumin is an acute phase reactant for a lot of things. But proteinuria, there's something going on. It's the low albumin is also from big time proteinuria. So I am trying to think of what would be in this age group, lymphadenopathy, proteinuria, without cells, and adrenal hemorrhages, if it's even related, because when you have high proteinuria, you're often hypercoagulable. You pee out more your anticoag factors than your coag. But if you've had a clot, which does happen sometimes bilaterally in the adrenals, I kind of think of adrenals as end artery, then you can get a secondary bleed. So I don't think this is an APS kid, but so in other words, I don't think this is antiphospholipid antibody. You can get a nephropathy, but it usually mimics GN. So there's usually red cells. There's not necessarily CAS, but the red cells are because they've actually got lots of microthrombi. Their podocytes don't work right. They're leaking out protein, but it's usually not to this degree. I would wonder, has this guy clotted his renal arteries? But it sounds like on all these imaging so far, nobody's kind of tweaked to that. So in other words, I'm saying a lot of stuff because I don't know. I'm trying to think on my feet. So Daniel,
Yeah.
to add to that.
Yeah, no, I wonder do you think the ACR is so low because he's peed out so much albumin already that
I just don't believe it.
Oh, okay.
I don't believe the urinary ACR. I believe the 4+ protein. So
Yeah.
I never would have done it. And so it is abnormal, but it should be like,
For sure.
way up there on the top floor.
I just wonder because like ACR checks your albumin ratio, and if you've already peed out so much albumin, I just wonder if like a PCR would have correlated better with the urinalysis. Not really that important because I think a 24-hour urine collection to characterize exactly how much protein would be important, because and Janet, I know you've made the clinical diagnosis already, but I want to make sure that we really do have nephrotic syndrome, right? He's hypertensive, severe proteinuria. We're trying to confirm exactly how much protein he's losing. We guess a lot.
Right. 13 grams. How's that for a guess?
That
A precise guess.
Fair enough. Okay. What I was kind of happy about is that there are places to look for tissue. So we have fluid. We have bilateral effusions. There's some fluid we could think about. We have ascites, easy, right? Our overnight residents would probably be quite comfortable taking fluid off the abdomen. And we now have lymphadenopathy, including paratracheal lymph nodes. I think that this means that we have places that we not just have for potential biopsy sites, but like we really should, because, okay, just like thinking about lymphadenopathy and what I'm, we're saying clinically this looks like a nephrotic syndrome. What about a lymphoma, right? And I think that means we're kind of obliged to rule out some of those disorders. Splenomegaly, lymphadenopathy that's above and below the diaphragm, young guy, I think I'd want to make sure that we actually do get maybe fine needle aspirate. Fine, they're probably going to ask, say, let's do that first, and then we'll talk about an excisional biopsy. But I would really not drag my feet too long before saying, take out a full lymph node so that we don't miss some of our diseases that require some of that architecture, maybe sarcoid or certain lymphomas and things of that sort. So That's sort of what I was thinking. I hadn't put the whole case together, but I just kind of had an idea of what my next step is. So Janet's like 5 steps ahead, and I'm like planning 1 step ahead.
No, we're both doing a little bit of baby steps right now. But honestly, if I was, I think to get a 24-hour urine collection is actually really difficult because this kid's sick and he can't even get up, and then he's gonna quickly use the urinal or whatever. I mean, they'd probably stick a Foley in him anyway. But I don't think today it matters so much because it's super high, and you can have pure nephrotic syndrome without red cells, even though that's not what we tend to see in rheumatology. And I think maybe because I think they're nephrotic, a lot of the people that we'd be seeing with lupus, etc. But I agree that we got to worry about, is this guy, like, is this lymphoma? Is it a bunch of reactive nodes? Is it sarcoid? Is it one of our kinds of diseases? I don't think it's post-infectious, like we don't have this post-strep GN kind of history, but they're not so nephrotic usually of post-strep GN. They're usually nephritic from my understanding. There's some of these syndromes that are heart kidney that, of course, I'll never remember what they are. So I think I'd like to also know a bit about his heart, but it could all be that he's tachycardic because he's working hard with a bit of anemia, but with, critical illness here. So yeah, I'd like drain a pleural effusion, get a lymph node biopsy, or get some peritoneal fluid and do flow and culture it for anything that ID thinks could be on the differential. Thinking that, if this guy is hypercoagulable, that might explain the adrenal lesions. And then I think we're kind of back now to treat and diagnose. So this guy would probably need like IV Lasix. Maybe he'd need spironolactone. I don't know what he's going to absorb, to be quite honest. So metalazone, oral, or just lots of IV Lasix at the beginning, and group and reserve just in case his hemoglobin falls, because it might not be as bad as it sounds with him being so hemodiluted, but I don't know. And I'd group and reserve him anyway, because if you're going to get a kidney biopsy, you want to do that anyway. So they're the things I'd be thinking. So we're going to just treat his basically huge amount of total body edema while we're trying to figure out what the heck's going on. By the way, is there any family history of anything of relevance?
Nothing of relevance, no. I think he had a paternal grandmother that had, I think it was Lynch syndrome. It was a hereditary cancer syndrome. But that was the only kind of unusual thing on family history.
Okay, so maybe we will turn back over to you. Where did you folks go next in the case?
Of course, he was admitted to internal medicine. And they felt what they were most worried about was lymphoma, just given the lymphadenopathy and cytopenias in a young guy. And they figured that maybe some of the pleural effusions and whatnot could be malignant. Though the differential did include autoimmune things such as SLE. They considered infectious stuff like Epstein-Barr can cause some splenomegaly and whatnot. So they did a whole bunch of workup when he got to the ward. The infectious workup, though, was pretty bland. Nothing really showed up on blood or urine cultures. They did HIV, Epstein-Barr virus, CMV, viral resp swab, Hep B, Hep C, all nothing. They did do an echo, and that was actually showed hyperdynamic LV function. So his heart was really pushing to really keep up with all this. I think his EF was 75% or something like that. And they did have a small pericardial effusion. They did some general rheumatological testing. And interestingly, his ANA was negative. ANCAs were negative, RF negative, and complements normal. In terms of the fluid, getting a sample, they did do thoracentesis and paracentesis, and that was also pretty bland. No malignant cells. He was actually borderline Light's criteria. I believe technically it was transidative. And he had a low SAG. So the serum ascites albumin gradient indicating that it wasn't portal hypertension. And the culture and gram stain were negative for what it's worth on both of those fluids. Hematology was the big step on their end. So they said, hey, could this be lymphoma? Um, Hematology was a bit worried about that too. So they requested a lymph node biopsy. But we really had a hard time getting anybody to do it because they were
Uh,
so small. So interventional rads said, this is just not going to be possible because they're so small. Um, General surgery said this is not something that we can easily obtain, and they didn't want to put him under GA because of his rest status. So hematology just went ahead and did a bone marrow biopsy. And I'll just cut to the chase about the results on that. So it didn't show any evidence of hematological malignancy, but it did show extensive reticulin myelofibrosis and megakaryocyte hyperplasia. And the report said that they favored this to be secondary to a systemic inflammatory process, but didn't really give any differential per se. So hematology overall, because the bone marrow biopsy and peripheral flow was normal as well, and this small volume lymphadenopathy, they didn't really suspect the heme malignancy piece too much based on that, although they still did want a lymph node biopsy. We actually did also call thoracic surgery to try to get an ultrasound-guided endobronchial biopsy, like you said, Dr. Ennis, with that paratracheal node. But when they lit him down on the table to do it, he actually had so much orthopnea that they had to abort it.
oh my gosh.
So, again, very hard time getting a lymph node biopsy, which made the diagnosis kind of tricky here. So I just gave you guys another big bolus of information. Any new thoughts?
Okay, I have one thought to add here. I think reticulin myelofibrosis is the R of Tafro syndrome. So like I really do. I want to be careful not to just be like, well, this is a podcast of weird cases, so say the weirdest thing you can. But I think like if I didn't know what that was on the biopsy, heme signing off is not going to be sufficient for me to not look into it. I wouldn't be like, oh, okay, well then then it doesn't matter. I'd probably go home and be like, okay, like what, type all this stuff into whatever your AI of choice is, or hit your textbook, or however you look things up. And I'd be like, is that a relevant lesion? And I'm pretty sure that is a component of Tafro, and the ferritin, not being terribly high, I think is also a feature of it is, I believe, a feature of Tafro as well, that they have a very high CRP, a high ferritin, a very high D dimer, but the ferritin's not terribly high. It's like elevated, but not that elevated. So there's like that discordance, and there's you folks have I know Newfoundland isn't part of the Maritimes, but in Nova Scotia, there's a hematologist who moved from BC to there, Luke Chen, who is kind of basically a hematology rheumatologist. He's such a good rheumatologist. He's solved some of our tough rheumatology cases for us. An honorary rheumatologist, I should say. And this is kind of an area that he's talked about to us a couple of times. So it's ringing some of those alarm bells. But off the top of my head, I would probably run that by that hematologist or whoever's on service and be like, are you sure? Like, is that a group of diseases that we should entertain? Do we need to do like soluble IL-2, or are there other fancy tests that I don't know about those, but you guys know, to rule that out? Because this isn't smelling, even serologically, like a straight up standard rheumatic disease, and we've not found an infection, we haven't found a malignancy. So, now we're starting to get into the weird stuff. That's what would be on my mind. Janet?
Yeah, so Daniel, a 22-year-old kid does not have myelofibrosis in any situation in their marrow without something being either genetic or some weird syndrome thing, right?
Yeah.
This kid's 22. Like, myelofibrosis is not a disease of 22-year-olds, and the reticular thing, I'm not sure how that expands or doesn't expand, narrows a differential. But also anything that I'm thinking of as acute phase reactant stuff would not have fibrosis in the marrow and like acute phase reactant in this, in the setting of post-viral or whatever we want to sort of say, oh, we've ruled out all this stuff. And his platelets are low, not high, which doesn't go with any of my reactive thrombocytosis things. So I think that you would have to really think about, I agree, getting hematology back, saying, okay, flow's fine. No one can do a lymph node biopsy. They're not giant, the nodes now anyway. But there has to be a differential here that we can find something to say, rule out, rule in, so that because we don't even know how to treat this poor guy right now because we don't have any diagnosis that makes sense. And I'm not sure with the other part because I missed it, but there was mega karyocytes or what else was in his marrow?
Megakaryocyte hyperplasia.
Yeah, so that's kind of weird. So if he has, I don't know why he has megakaryocytes. He's got some kind of consumption going on, but the spleen isn't giant yet. So I think that we would need to call the hematologist back and say, please point us in the right direction. Daniel, is brilliant you saying that syndrome, but since I don't really know much about it, I can neither confirm nor deny.
I kind of only know the name. We get called on these cases too. And so sometimes you just happen to bump into it, and it's a bit of a Slumdog Millionaire situation where like, oh, I think I saw a case like this like a little while ago. Like it's not through reading, but just by doing this job long enough, you start to see weird stuff. And I certainly don't know enough about that condition to be like, oh, classic, multicentric Castleman's. Like, no way, like. That's just something that we sort of share with hematology. So I agree. Like I'd get them on the horn again and maybe twist their arm a bit to look at some of those disorders before they sign off. So Stephen, back to you. What did you folks do next?
Yeah, so like you guys were saying, this is kind of where the beginning of the diagnostic dilemma came. Because up until then, I think the team was just kind of hoping, hey, we sent off this plethora of tests, something on the computer is just going to come up. You have lymphoma or you have whatever, right? But then when that doesn't happen, it kind of makes things a little more complicated. So basically, he's been 2 or 3 weeks into the hospitalization now, actually, and still no cause for the very high CRP, volume overload, lymphadenopathy, splenomegaly, renal failure, adrenal hemorrhages, and cytopenias. So they consulted Rheum. Like you were saying, this is usually where rheumatology comes in. And Rheum kind of wondered about whether there could be potential for sarcoidosis here. So they actually recommended a PET scan, which ultimately showed diffuse low FDG avid small volume lymphadenopathy. But the report again said that nothing will be easily sampled. Rheum ultimately didn't think there was really an autoimmune explanation for all of this, but later they did wonder whether there could be something maybe autoinflammatory. They were also in a bit of a dilemma, so they actually recommended genetics consultation. Genetics did do whole exome sequencing that later showed no genetic abnormalities. They consulted ID, just thinking, hey, these are the closers. Maybe there's some weird infection that could explain all of this. But they didn't think there was anything, especially because he remained afebrile and all of his cultures and imaging didn't really point to it. He had no travel history either. And in Newfoundland, we really don't have anything that exciting from an ID perspective, I hate to say. And again, I think the team tried talking to GenSurge again. Hey, we really need this biopsy. And again, it just wasn't something that they were too excited to try to do. So the bit of the dilemma now that I'll pitch to you guys is that he actually starts to get a lot sicker 3 or 4 weeks into the admission.
Because nothing's being done because we don't know what to do.
Yes, exactly. He still hasn't actually had any kind of disease-directed treatment here. So he's actually relatively suddenly, like I'd say over 2 or 3 days, he ended up going up to 6 liters of oxygen. He had actually looked very uncomfortable. I would describe it maybe moderate work of breathing. And I actually came on service around this point. Just FYI, a lot of this had happened before. So I came on and I said, like, geez, this guy's 22. He seems super sick. We have no idea what's going on with him, basically. What are we going to do? So I'll pitch it to you guys. Now that he's getting a little more acutely unwell, what do you guys think he would do?
I mean, first thing I'd do would be call Janet and be like, "Hey, you got any idea what's going on with this guy?" This I think is like one of those cases where like you wherever the other specialists involved in the case are in the hospital, you grab them all and you get them in a room and like this is one of those multidisciplinary conference sort of cases. I think like where everyone starts to look at this point is towards glucocorticoids. Maybe Jen has another feeling there, but I think everyone's gonna be like, hey, like, should we give him steroids? Like, should we just like call it a room thing and like then it's rheumatology's problem? Because that's sort of that can be an easy out, and it's not necessarily wrong. It's just like you want to do your due diligence about like, okay, like what can we do before we just give steroids, because that helps all sorts of stuff. I suppose you also want to make sure he's not adrenally insufficient after he, hemorrhaged both of his adrenal glands. So like that's not a component of, whatever incipient hypotension he was eventually going to get. So I think that would be like step one is like clarify everyone's certainty about yes or no on certain diseases. Pitch some weird stuff to each other and bounce it off of each other. Because if someone pitched like sarcoid, like that is a good thought. And like that is something that we should think about. But, there's some important stuff missing. But maybe you would say stuff like, you know what, okay, it could be sarcoid. Maybe we should have ophthalmology look for subclinical uveitis, because that would maybe tie things together a bit. Maybe that would pull it together. Maybe we should MRI the brain, look for like neurosarcoid stuff and leptomeningeal enhancement and stuff pitching those ideas can kind of expand some of your diagnostic possibilities a bit. Essentially, like, everyone gets to be a bit more imaginative, and sometimes I lack imagination. And so I think that's what I would do. Janet, what do you think?
I mean, of course, it goes without saying that the ABCs, because airway and breathing, this guy's going to need to be tubed soon by the sounds of it. So I would make sure fluid balance, that you can diurese as much as is safe, because I don't know how big the pleural effusions are, but his albumin is probably not going in the right direction. Totally. And transfuse him if he's having a hard work of any oxygen carrying, because if he's quite anemic. So airway, breathing, the major things like we can do his sodium, potassium too, because he's probably been diuresed the whole time, but all that kind of stuff. But that's a given, and that's where on the wards, and maybe even like getting an ICU consult just in case. Hey, have you guys got beds? And we've got a young guy here who might get kind of tired out. He's been in high output for 2 weeks now, and probably a month before that. So he's getting tired. But I really think that I would be very, very driven to give glucocorticoids high dose, saying, I don't know what the heck we're treating, but we might be able in this case to do potentially more benefit than harm, even though I don't know what I'm treating, because I think we can say lymphoproliferative sounds to be ruled out and infection is ruled out. So in the end, if it's sarcoid, weirdo genetic syndrome that I've never heard of, that no one else has kind of come up with yet, but maybe we'll come up with later in the case. Yeah. We're not going to really hurt that. We got to still treat. We got to get, this guy has to stop the proteinuria and things. And it's not sounding like amyloid. And amyloid would have been found by now. It would have been seen on echo. And also he'd be a young guy. It'd have to be like, you don't get primary amyloid at this age, and you don't get, I'm just trying to think of other things that could give you nephrotic, but usually we would have a lot of other clues. So I would probably give the guy, not knowing what I'm treating and being quite honest about it and talking with the patient and the family if they're there, that if we give glucocorticoids high dose, it might help him feel better while we're still having like discussions on what's going on. Mm-hmm. So I know it's like our vitamin in rheumatology. Here, have some steroids. You'll feel better. I'll feel better, but we still don't know what's going on. But we might buy some time. Yeah. So that's what I would suggest. But I also think, we might really need, I know he's really sick, but we might really need a renal biopsy. Mm-hmm. Like, I don't mind giving him steroids first, but let's get another chunk of tissue. Like the proteinuria is presumably related to this guy's anasarca, the low albumin, and being now more critically ill, or at least a lot iller. Go for tissue. Just try it again, because the nephrologist could do it, or the radiologist. I know his INR at the beginning was up. I don't know what it is now. If the INR is 4, that's a little bit scary, because I don't know that you want to give this guy a bunch of fresh frozen plasma to do a biopsy and then he just leaks it all out. But anyway, that would be some of my thinking. I don't know that there's money in the brain. I don't mind it being imaged, but because we haven't heard he's confused or headache or anything like that. But right now I'm lost.
Yeah, I agree with that. It's kind of steroids time. And I guess we sort of didn't talk about renal biopsy earlier on, but I think that probably would have that would have been at least something like to discuss. Like, is it going to be like in nephritic syndrome, like you do a biopsy, right? Like we need to know like what's the nephritis, what kind. It matters very much. I just don't have quite as much personal experience with nephrotic syndromes, and whether the biopsy really it does help you narrow the differential, but is it going to help narrow this differential where we're kind of like, there's clearly an inflammatory process. So I that is something that I need a little bit of help from internal or nephrology on. Okay, so Stephen, what did you folks do next? So this is like day 2 for you on service. You've read through 1,000 notes on this guy. He not mysteriously has worsened in hospital because we've just been watching him as you've waited for some pretty aggressive testing, right? Like you folks are pushing pretty hard to figure it out. What did you all think?
Yeah, it's pretty true what you said. Whenever you come on a service, you read a list. And this guy, I think I spent like 3 hours reading his whole checks, just trying to untangle what was going on there. But anyway, so pretty much where you guys were going with it. In terms of the renal biopsy, that's interesting. I don't think we really went there, but nephrology was involved a bit earlier in the course for the renal failure, and they actually felt, I guess, neph magic in some way. They had figured out that he was intravascularly deplete, so they thought that maybe his renal failure was
pre-renal.
Pre-renal, so they actually recommended just gentle fluids. Yeah. So he had been getting just a little bit, I think 75 cc's an hour of fluids, but it didn't really help with his renal failure. But in terms of the acute illness, so we did pull the trigger on empiric steroids at that point, also with just a kind of a shrug. This could be anything, sort of, but he needed something to make him better. So we did hydrocortisone, 100 milligrams, IV Q6H, pretty high dose. Basically for inflammatory condition NYD. His CRP actually did improve quite a bit. It went from 138 when we started steroids to 40 after a week, and then by 2 weeks it was down to 13. He did continue to have pretty severe third spacing though clinically. So we ended up putting in some drains at that point just to mechanically get the fluid out. And actually this is pretty incredible. So it took 3 weeks before these drains could actually come out because of the vigorous amount of fluid that was coming out. And in total, over these 2 or 3 weeks, he actually had 15 liters out from each lung and 30 liters out of his abdomen. Can you imagine? That's 22 years old.
Absolutely. Like, I do want to reflect, like, I mean, Janet's seen a great deal more patients than I have. But, like, I've seen 0 patients with standard, like, it kind of are typical rheumatic diseases with that much fluid leakage, like just like literally like losing gallons and gallons of fluid. I haven't really seen that. Not impossible, but that sort of starts to push me towards some of these, like that may also be a window into the case, like high volume serositis or high volume anasarca. Does that start to distinguish between entities the way, you might say like, oh, there's high ferritins and then there's like really high ferritins, and like there are sort of like levels that distinguish different types of diagnoses. So I might hit the books and look at that and be like, oh, what does that? Maybe that helps me solve it too.
Would you use a chat bot? I wonder if you said, hey, Chat GPT, here's this guy's records, obviously anonymized. What's the differential? Because I'm still fixated on why a 22-year-old has a fibrotic bone marrow change. I know, I don't know what's going on, but I know in my heart that some kind of syndrome it's going to be like, look up what gives reticular myelofibrosis
Yeah.
and anasarco-nephrotic syndrome, and some weird mutation-ish things are going to come up.
Yeah.
And I think he's going to have one of those things. And maybe this is truly where I would say, let's get Chat GPT. If all the specialists aren't really sure and the guy is responding to steroids, steroids are so non-specific.
Hmm.
I think this guy has one of these weird syndromes, yet to be named by me, at least.
Right. Yeah, Pope syndrome, right? Yeah, I agree. Like, I think this is like, that's a good adjunctive use of an AI to at least like generate a list for me. Also word it in a way that doesn't make me feel too bad about myself. And like, like just expand my list a bit. Like I am missing a group of diseases here, or like this isn't something that I see routinely. So in terms of having those various levels of kind of expert data synthesis, like Janet sees a case and knows everything about them right away. You've seen her do that on this podcast, right? She sees that the ANA is centromere pattern and kind of knows the whole case and looks like she's predicting the future. That is really hard to do for diseases that we bump into so rarely that it's not possible to have a statistical pretest probability, right? And so I think it's like, that's a good place to maybe use an AI to be like, tell me what am I not thinking of? So I agree. I would totally do that. I'm not too proud a rheumatologist to ask for help. So this guy, so you gave him steroids, you're seeing objective improvement in at least serologically. It took weeks for the serositis or the anasarca, I should say, to calm down, but it sounds like it did. So this is a steroid responsive process, though it's taking time. Now, that is the treatment side of things, and obviously, like, high dose prednisone is not your long-term solution. So we still don't have a diagnosis. I'm leaning towards one of these, Castleman's adjacent disorders. I really do want, now that he's healthier, now I want all that tissue I wanted before, but now it's probably gone. So that's the catch-22 of catching these people too sick, is now it's sort of too late to make maybe a diagnosis up front. What did you clever people do?
So it's pretty funny that you brought up the AI piece. It'll be relevant in a second, I promise. But basically, the big break in the case, I think, basically, I was in bed about to go to sleep, and I was just reading differential stuff, actually literally up to date. I was just kind of doing what you said, just looking up each of the symptoms and saying, what is the weirdest differential thing for each of these? And on the lymphadenopathy thing, I came across something that I won't say yet, but I literally couldn't believe it, how well that it matched. I'd never heard of the thing before, but it felt like a eureka moment. I was like, this has got to be it, even though it's a zebra. So I literally ended up jumping out of bed at like 11 o'clock at night and wrote an EMR note. Super nerdy, but I was really excited about it. But I was humbled greatly because the next day I went and talked to the patient, and his mother actually had Chat GPT'd, and the first thing at the top of the list was the same thing that I was thinking. So AI, it actually worked, yeah. So I felt a lot less cool about it when AI actually figured it out easier.
I actually think you did such a good job, right? And like, part of that is not bringing ego to the diagnosis. It's not really about us, right? And it's not about being right or clever, or I guess it's about being right eventually, but it's definitely not about like who's right or how you get there per se. Our process is important, but like, also the fact that like it wasn't hidden. It was on the up-to-date article when you looked up the individual symptoms, right? So, solving things through perseverance and tenacity, I think, is sort of a better process than solving it through just like being a genius or something, or having an eidetic memory, right? Being willing to sit in bed and grind and just like read through as much stuff as you can until you solve it, I think is awesome. And this guy wants to be a rheumatologist. We are lucky
We're
to
so
have
lucky.
Stephen Rose in this world. All right, so Stephen, you solved it. Was this?
I'm occasionally right.
Yeah.
Mostly not, but
All right.
getting there.
I can't stand the suspense. What did you figure out?
Yeah. So kind of just getting to the point of all of this. The family actually moved this forward. So I had brought up the idea of this diagnosis, and because it was pretty rare, I don't think anybody at our center was that comfortable with it. We are like a relatively smaller center, I guess, in terms of Canada, although we're in the capital city of Newfoundland. But basically the family moved it forward because they kind of latched onto it, and they started Googling, and they found out that there's an expert in this particular disease who they reached out to, and the expert was like very happy to help out. And they said, it actually could be that. So they got in touch with the SAF doc that we're working with, and they kind of made a plan to kind of sort this out. So I thought that was great. The family really played a pivotal role. So basically the condition has a pretty big mortality, I would say, without treatment. So this ultimately convinced GenSurge to kind of just take a stab at it. Like, let's get tissue.
Literally.
Yeah.
We
Which is-
literally.
Yeah, literally.
I bet they make
But
that
it's
joke
fun.
all the time.
Daniel's still on Tafro syndrome, and I am too, even though I don't really know what it is. So whatever that thing is, that I'm in.
Who
But
knows?
okay, so they got the lymph nodes from somewhere, who knows where.
Yeah, but funny
Abdominal.
enough, they actually did have a really hard time. They actually had to scrub out in the middle of the OR, look up the CT scan again, then go back to
To
try to find
find it.
lymph nodes. So they were right,
Because-
actually. Like, it was
Oh
very
my
hard,
gosh.
apparently.
Yes,
What a
because
nightmare.
they had already shrunken with glucocorticoids. So
Mhm.
not specific of what that treatment did. Okay, so the drum roll.
Drum roll, please. Yeah, so the preliminary diagnosis on the lymph node said an atypical lymph node with hypervascularity. And it described the atypical features as being prominent high endothelial venules, regressed germinal centers on a hypervascular background. And as tends to be not super satisfying, sometimes, the report just said ultimately this is felt to be reactive changes from some systemic inflammatory process.
Boo.
Didn't really have a clear diagnosis on the screen, but they did feel confident that it wasn't hematologic malignancy at very least. But yeah, it didn't really bring us much further. And this is the last question that I'll pose to you guys before I finally reveal what it was. But what do you think of those lymph node results?
Not surprising. Everybody who's got reactive hyperplasia, who's still alive 4 weeks into hospitalization with no specific treatment other than a whiff of, not a whiff, a big whiff of steroids. So I'm a little bit discouraged. I was hoping some weird stain would tell us something. I think, again, it's always, we want the answer in black and white, and sometimes the answer is gray, and it's putting it all together, the splenomegaly, the myelofibrosis, the anasarca, and numerous other things. I think, I really think that there's probably, being that up-to-date thought of something, that there's something that, although maybe it could have been a pathognomonic thing on biopsy, the guy's treated, and it's still, in a way, although he's quite sick, early stages of the disease. Daniel, what do you think? Like, were you kind of hoping the biopsy would be the holy grail?
I gotta say, like, that's something where that is the very outer limits of my knowledge. So for the diagnosis that we thought it was, is one, we would have to know, okay, does glucocorticoids erase the pathognomonic biopsy features of it, and therefore this is a non-trustworthy, like, it's the best we could do, but it's an inconclusive biopsy, but doesn't rule it out. That's stuff that I would have to look up or talk to like an expert and say, like, is it likely to be positive at this point, and are these the standard findings? So, like, it's just knowledge I don't have. So the fact that it didn't show pathognomonic features, I actually don't know if there are any. That's something that's a bit outside of my wheelhouse. But I would kind of point out, you have achieved a pretest probability for that is relatively higher for a very rare disease, but now it's a bit higher because you have ruled out every single other thing you can think of. And check, this guy kind of meets all of the criteria for, Stephen, you've been very good about not telling us what the diagnosis is yet, but right, you said he looks exactly like it. So at some point, that's an appropriate diagnosis, even if it doesn't fit perfectly. And we can admit that this person's partially treated. So, it's just outside of my expertise. Yeah.
And I still, if we're going to have to guess, I still think Daniel was barking up the right tree early on, saying Tafro, though the guy didn't have a fever. We can't help that. Or Castleman, like, I don't know, because these are rare things. But again, there's not a lot on my learning curve that is the reticular myelofibrosis. So I have to keep coming to that plus anasarca and thrombocytopenia because they're the consistent things. Everything else, because of the anasarca, the proteinuria, the nephrotic, that's why you're going to have ascites, I assume, and have your exudative-ish pleural effusions, et cetera, and a small pericardial effusion. So it kind of could tie in a lot of stuff, but I think we do need the drum roll, and you can spell it out for us. I have a feeling I'll go, never heard of it, and now it's on my list.
Me too. I'm be like, no idea what that is. All right, teach me something new, Stephen. What does this guy got?
So, like you guys were saying, because the clinical picture just seemed like it could be maybe the only explanation, we actually went down to pathology and just told them what we thought it was, so that they might take a second look with that in light, kind of framing it. And huzzah, they said, now when we look for it, it does show kind of the pathognomonic sort of things. So ultimately, this diagnosis is Tafro.
Daniel was early on, and I agreed that he got it first. Yes, but there was no fever. He had everything else, but maybe there was a fever before.
Yeah. So it's kind of interesting, and I'll kind of just briefly go over what it is, basically, just because I think it's useful for doctors just have some sense that this exists, because it's a treatable condition. But it can have fever or elevated CRP. So because he had the high CRP, it kind of still counted. But about 80% of cases have fever. So he was just kind of an outlier there. But so Tafro syndrome, actually, almost always is associated with a benign, as in non-malignant, hematological problem called Castleman disease. So it's IL-6-mediated lymphoproliferation. So you get swollen lymph nodes. But there's a subtype, without going too far into the weeds, but it's called idiopathic multicentric Castleman disease that just causes systemic inflammation. That's, again, IL-6-mediated. And it can cause a lot of these features. But then one of the rare subtypes of that is this Tafro syndrome that presents basically like a cytokine storm syndrome, where they get super sick. The mortality is actually about 30% over a couple of years. So a pretty significant problem. And it's very rare, about 1 in a million, something like that. And it's a hard diagnosis for a couple of reasons. One is just it was only discovered in 2010, so it's not really something that's taught in med schools per se. But also, there's a lot of mimics of it, and there's no kind of pathognomonic thing that you order a whole slew of tests and the computer shows up, bingo, you have Tafro. Like, it's kind of something that you had to have kind of an awareness that it exists and just kind of clinically put it together. So technically, the lymph node biopsy should have pathognomonic signs on paper. But if you talk to experts like Dr. Fagenbaum, who you guys actually had on, he was the expert that was involved in this case, actually. It's pretty common that the path report just says kind of reactive changes. But then sometimes if you prompt or kind of talk to pathology about it, sometimes they're able to find some of these more typical things. Onion skinning is a classic word that they find. So basically the picture, just to kind of say what Tafro stands for. So it's TAFRO, so thrombocytopenia, anasarca, fever, The R is reticular myelofibrosis / renal failure. And the O is organomegaly. That can be lymphadenopathy / splenomegaly. And classically, it is like mild splenomegaly, kind of like he had. And the lymphadenopathy is pretty specific. It's like small volume, less than 2 centimeters, and it's low FDG avid on the PET scan. So not super lighting up. And actually, kind of circling back to a feature that got lost because it was so early, but and this is when I really said, geez, like it's just got to be. Adrenal hemorrhages are actually something you can see in this condition. So I said, geez, like all of these like kind of very niche things, the myelofibrosis, adrenal hemorrhages, and actually you do tend to get CRP like 100 to 200 range. The ferritin tends to be around 1,000. The ALP tends to be isolated up a bit without the other liver enzymes being up. So it was really just too perfect. And even microcytosis, apparently there's some hepcidin-related process that causes some microcytic anemia. So it was just bizarre. And the treatment is anti-IL-6.
And you know, Stephen, if we would have looked you up, I did while we were saying, I looked up Tafro on PubMed and CMAJ, Stephen Rowe came up.
Very
So
good,
they've
Stephen.
written up the case, and had we done homework, which we didn't need to do, we thought, for Mysterious Case, we would have said, we would have acted like we didn't know anything and then said, oh, it's obviously Tafro. Yeah. No, that is really, really important. And I think going back, like it was bounced around, like Daniel pretty quickly said, and I got hung up on what the reticular myelofibrosis and really nephrotic would be. But putting those two things together early on and without a fever, Tafro wasn't coming to mind. And let's be honest, I really don't know much about Castleman's or Tafro, but I love that this made us go through a very scientific, logical method, and that's what the team had to do as well. I also think that when you change the question for pathology or for a radiologist or for the colleagues in other specialties, if you frame the question differently, you do get a broad and differential or a different answer. And it's because always knowledge can be, in hindsight, we go, oh, yes, of course, it was staring right in front of us. But that's what we do in medicine because we have to narrow it down and then, get on with then what is it? It's not. So how do we rule in? So that is a really, really excellent case because this kid hopefully is now going to be on his IL-6 inhibitor, of which we even have a biosimilar of one of them these days as well. So hopefully, he'll be doing well, get off of glucocorticoids and get back on with his life.
Yeah, he's actually, this is the best part of the whole case, is that he's actually doing amazing. He's back to his studies. He's completely asymptomatic. He doesn't have a single flagged blood work value. And this is, I would say, over a year later now. Yeah, this is about a year and a half after the fact. So he's maintained on siltuximab. It's kind of a Castleman-specific IL-6.
Well, Stephen, you really modeled being a great doctor, right? Because if you can't be outworked, you're not going to be outsmarted. Like if you just keep plugging away, reading, thinking, listening to the family, right? Because they too did, in some ways, the jobs of that was challenging for the medical team. Like eventually you very well may come up with the solution to a 1 in a million case, and you prove that. So if there are any young listeners who aren't already rheumatologists, I think like that models, I think, really a good work ethic. That's going to beat being, I'm not calling you not clever, but being a hard worker is going to beat being clever 9 times out of 10, right? And it's nice to see that you're actually both. So that's great. Well, thanks very much for bringing such an interesting case to us. I really appreciate it. And we'll let you go. It's getting late there.
Thank you. That was really, really interesting.
That's it for this episode of Around the Room. For questions, comments, and future episode ideas, email us at info@room.ca or tag us on social media. Around the Room is produced by David McGuffin, Dr. Dax Rumsey, and Aaron Stewart. We'd like to give a special thanks to the Communications Committee and the staff of the CRA for their hard work. And of course, an extra special thanks to Dr. Stephen Rowe and Dr. Janet Pope. Our theme music was composed by Aaron Fontwell. If you enjoyed your time with us, please give us a rating and write a review wherever you listen. It helps people find these interviews. And be sure to subscribe so you don't miss future episodes. Until next time, I'm Daniel Ennis. Thanks so much for listening.